Thanks, Ardy, for that. That was great, and hopefully I'm going to be able to now give you some advice about what we've been doing locally in order to implement some of these new treatment strategies that we have for asthma. I'm going to have an attempt at using the clicker and see if... Oh, it's back working again. Must have just needed a little bit of a rest. So I'll start with this one. Similar to what Artie said, asthma is an inflammatory airways disease, and therefore we must be treating that inflammation. And we know that short-acting beta agonist, that blue inhaler, does not treat the inflammation that's in the airways. So that's an absolute must. And I always use diagrams, models and things like that with patients so that they're all fully aware of what's actually going on inside their airways. Because if they don't know what's happening inside their airways, then they're going to pick incorrect treatments. And we'll talk a bit more about that as we move on. This is a drawing by a friend of mine, Frances Barrett. I work with the Primary Care Respiratory Society, and this is the kind of pathway that we could lead our asthma patients down. We could potentially end up leading them down that dark, grey, bleak left-hand path, which is a very reactive management pathway where the person has a lot of symptoms. They possibly end up with that airway remodelling and tissue remodelling that ends up with fixed airways disease down the line. And what we want to do really, and what our job is to try and guide people down this bright, optimistic green path, which is your proactive asthma management path. And we have the tools and the ability to be able to do that. So just to set the scene a little bit and follow on from some of the things that Artie mentioned, every 10 seconds here in the UK, somebody's having a potentially fatal asthma attack. That's quite a large number of asthma attacks that are going on there, something that is preventable. Every 8 minutes, somebody is being admitted to hospital, and the saddest statistic of all is that on average, 4 people die every day of their asthma, something which is reversible and something which is preventable. Similar graph to what Artie showed you. My data is just a little bit older, but it shows exactly the same thing. So it kind of shows that we're not improving. This is age standardised deaths, and we sit at the top of this table, and it's a table that we really don't want to be at the top at. For some reason, we don't do very well with asthma care here in the UK, despite having a fantastic healthcare system and access to all of the medicines that could help people. And I was talking to Andrew at the start. If any of you have been around long enough to have been at the Respiratory PLI in 2015, Dr. Mark Levy stood right here. He was the clinical lead on the asthma review of asthma deaths, and he told us about the things that he had seen during that study, and you know it was quite frightening, really. The data that we pulled out of the National Review of Asthma Deaths, and it's actually bang on 10 years ago this month, was NRAD. And 2 weeks ago, Asthma and Lung UK produced a 10 years gone report. And you may have seen the headlines. These are some of them. Headlines that I don't want to see in another 10 years. 10 years ago, I thought that was the game changer when we had the National Review of Asthma Deaths, and yet we are actually in a worse position now. So what they said was there has been 12,000 people have died in the UK since the National Review of Asthma Deaths because of their asthma, and that's increased by 25%. So there's something we're not doing right, and we need to really change that. So this is just some of the information from that review. It's 10 years ago, but I'm standing here telling you it again today because it still all stands here today as well. 46% of those deaths could have been prevented if guidelines had been implemented. It's as simple as that. Almost half of those deaths we could have prevented if we were following guidelines. Key elements of that care were missing. So only 23% had a personalised asthma action plan, and I like to flip that on its head and say that means that 77%, over 3/4 of those people, did not know what to do in the event of their asthma getting worse. And 43%, almost half, had no evidence of having had an asthma review in the last year of their life before they died. And some of the scary statistics around the SABA prescribing, 39% of people who died had more than 12 salbutamol in the 12 months before they died. There was 4% had more than 50 salbutamols in the year before they died. And I've seen that in Sheffield. I've seen somebody receive that many SABAs for asthma, not COPD. There was one person who had received 112. Deep intake of breath there. It is understandable that people become reliant on their blue inhaler, their SABA inhaler, their rescue inhaler, their reliever inhaler, whatever we want to call it, because it does what it says on the tin. It's a bronchodilator. It opens the airways, and for that moment in time, they feel a little bit better. And so they become reliant on it. And I'm sure lots of us in the room have had somebody, can't not give me my blue inhaler because I might die. I've heard that from multiple patients before. And I like to say, I can't keep giving you your blue inhaler because the evidence actually says that people die if they do keep using it. And we have that evidence now. But it's a really risky perception from our patients that it's the best inhaler for them because it's not treating that inflammation. So their airways remain inflamed and they continue to get those symptoms, even though they might be getting that short-term relief. Oh, we'll just nip back to him there. Forgot to point out, any keen-eyed people might have noticed why, or might have been thinking, so why is your blue inhaler smiling? Why is he happy? Surely he should be sad. And that's because when you search for cartoon blue inhalers or just any pictures of blue inhalers, that's what comes up. That's the imagery that's out there. People think that blue inhalers are a good thing and we need to change that. And thankfully, I got some very clever artistic people to draw me a sad one. So now I have my sad SABA that I can use in future talks. Some of the other things that came up, look at this, when you search, asthma prevention and control. I'm not sure what level of prevention or control I see going on in that picture. Goodness knows what's happening with that inhaler technique, and it's a blue inhaler. This one. This was accompanied with the slogan, optimising asthma care in children. Blue inhaler, no spacer. This is the kind of thing that happens. And I like to tell this story about a film that I watched. It's called The Adam Project. I'm sure there'll be some people in the audience who've watched it. In The Adam Project, there is a young boy, and he has asthma. He has quite severe asthma, and he starts to wheeze. What does he do? Whips out his blue inhaler. What does he do with it? With his blue inhaler. 2 seconds. He's absolutely fine. To the point where when I was watching this film with my family, I had to get them to pause it so that I could have a rant about the fact that Hollywood must have much better bronchodilators than we have because they certainly don't work that quickly. So the imagery is all wrong. The messages that are out there are all wrong, and we really need to start trying to change that. So Artie explained this, that this is what we should be aiming for. We have a very high tolerance, I think, at the moment of asthma symptoms. And so do our patients. It's normal for me to cough. I've got asthma. It's normal for me to be breathless. It's normal for me not to be able to do the activities that I want to be able to do because I've got asthma. It's not normal. This is what the British Thoracic Society say is complete control of their asthma, and that's what we should be achieving. No daytime symptoms, no waking up at night, no needing to use rescue inhalers, no limitations on activities. So we need to really try and change our tolerance levels for asthma symptoms. And I think if we change those tolerance levels, that's one of the key things that we can do to really try and drive improvement in asthma care. So, on to the treatment algorithms. Apologies if these look slightly blurred to you. I have snipped them from the PDF, so they haven't gone brilliantly into slides, but you can Google Sheffield Asthma Guideline if you haven't seen it yet, or you can go onto the intranet and it's on there. Within the algorithm, within the guideline, we've got 2 algorithms. Treatment algorithm 1 and treatment algorithm 2. This is treatment algorithm 2. You're probably thinking, why she put 2 up first? That's because I want to get this one out of the way. This is probably what you're more familiar with. This is quite similar to the British Thoracic Society guidance for the management of asthma, starting with a low dose inhaled corticosteroid, adding in a LABA, stepping up to medium dose, high dose, and referral onwards, and considering various add-on therapies throughout the way of that. In this algorithm, SABA is the you'll see, rescue/reliever inhaler. We've started to try and drip feed you that message that it should be seen as a rescue inhaler. Okay. The one thing that I want to point out about this is there is no place in this algorithm for salbutamol on its own. We should not be doing that. So GINA 2023 was really a landmark change for us in asthma care, because it gave us new treatment options that we haven't had in the past. And GINA are the global initiative for asthma. They don't class themselves as a guideline, they call themselves a strategy. And the idea is that we then have to interpret that for our local health economies. They have 2 treatment tracks. Treatment track 2 is similar to what I've just shown you. Treatment track 1 is what is their preferred treatment track. And what is used throughout that treatment track is a low dose ICS formoterol as the reliever treatment at every point throughout that treatment pathway. So this is just to kind of put into the picture that thing about mild asthma. Like Hartley said, around 10% of the people who died in the National Review of Asthma Deaths were considered to have mild asthma. People do die of mild asthma. Just because you might have infrequent symptoms does not mean that you are not at risk. And this was a study by Dusser et al., which kind of highlighted that 30 to 37% of adults with acute asthma had symptoms less than weekly in the 3 months before they had that event. 16% of near-fatal asthma had symptoms less than weekly. So they were only needing to use their inhaler on a weekly basis. And 15 to 27% of adults dying of asthma had symptoms less than weekly. And we know that exacerbation triggers can be variable. We don't know what the pollen count's going to be like tomorrow, or what the air pollution levels are going to be like on our walk to work that day, or when we're going to get a virus, or anything like that. And so we're leaving people really quite susceptible with current treatment strategies to needing courses of oral corticosteroids, which we absolutely want to try and avoid if we can. So why shouldn't we treat with SABA alone? It's been sort of first-line treatment since 50 years ago, and that's because 50 years ago we thought that asthma was a disease of bronchoconstriction, but we absolutely know that's not the case now. And it became popular because it was cheap, and it kind of did what it should do. But it is, it has, by giving somebody that blue inhaler at the start of their treatment, it trains them to believe that that is their primary and main inhaler. And so we give the wrong message from the very start of the treatment. However, and this sometimes blows people's minds, if somebody uses regular salbutamol, even for 1 to 2 weeks, it increases airway hyperresponsiveness. It increases airway eosinophils, therefore inflammation, and it increases allergic response, okay, and therefore decreases bronchodilator effect. I could go into the pharmacology of how that happens, but I'll not bore you with that today. But just bear that in mind. If somebody is using a lot of salbutamol, then they are potentially not going to get the benefit from that salbutamol when they need it. So thinking about as needed treatments. So this is the kind of the game changer treatment for asthma, for those mild, infrequent asthma patients. How did we come about using this? Well, there's been quite a lot of studies that have been done on this. 4 big studies, Sigma 1, Sigma 2, Practical and Novel Start were the 4 studies that were done. And they compared people using as needed low dose budesonide and formoterol with people who were using as needed SABA, or with people who were using fixed dose ICS and SABA as they needed to. And the studies kind of speak for themselves. A 60 to 64% reduction of severe exacerbation versus SABA alone. So quite humongous difference there for people. And compared with maintenance low-dose ICS, the risk of severe exacerbations was either similar or slightly lower. So people often say to me, So if it's the same as using fixed dose ICS, why don't we just use fixed dose ICS? And it goes back to what Artie was telling you about how poor compliance is. So these are people in a randomised controlled trial, they're part of a study, they're engaged in their therapy, they're probably reminded every day to take their puffs of their inhaler. We know that in real life that isn't what happens. So what we need to do is we need to try and change the inhaler rather than the behaviour. And this gives you the option to be able to do that. Symbicort Turbohaler 206 was the first one that was licensed, and that's the one that we've got on formulary here in Sheffield. But what the study showed was, and I often get asked this question, but what if people take loads of inhaled corticosteroids? You know, surely there's a risk there that people could end up taking a load of ICS. But actually the study showed that the daily dose was around 50 to 100 micrograms of budesonide, so really small doses, to give the same level of control for that patient. I'll not go through this, but this is just a meta-analysis of all 4 studies published in Cochrane, which showed pretty much the same thing. And how does that work? How can we use ICS formoterol as an as-needed treatment for asthma? And this graph, I think, depicts that. One of the things that I want to point out, and Artie mentioned this as well, formoterol is a fast-acting beta agonist. We call it a LABA, it's a long-acting beta agonist. I think we should start calling it a FABA because it's a fast-acting beta agonist. It works just as quickly as salbutamol does. So we can use formoterol as a reliever. So thinking about this top person is somebody who's on a bog standard salbutamol-based treatment regime. They are heading towards an exacerbation. The inflammation in their airways is obviously getting worse, and that follows by the symptoms. Symptoms come, so they reach for their blue inhaler, they take a puff on their blue inhaler, they might feel better for a short while, but then they need another puff on their blue inhaler, and another puff, and so on, and so on, and so on. Yet that inflammation doesn't go down because they're not taking anti-inflammatory treatment. So they get to the point where they need a course of oral corticosteroids because their exacerbation has got quite severe. If we have somebody on an ICS formoterol-based regime, and this is the same for the as-needed treatments or your maintenance and reliever therapy treatments that you're possibly more familiar with, same thing happens, they're heading towards an exacerbation. They take, the inflammation starts, they get the symptoms, they take a puff of their ICS formoterol-containing inhaler, they get relief. Brilliant, that's what we want them to get. But they're also inadvertently taking some inhaled corticosteroid at the same time. So they might go on and take a few puffs of that, and that dampens down that inflammation and hopefully massively reduces the risk of that exacerbation getting to the point where it needs oral corticosteroids. So this is just a summary of some of GINA's recommendations. Every adult and adolescent should have an ICS containing controller medication, and I'm talking predominantly here 12 and above. I'm going to leave Sonal to do the children's bit after the break, but you know it's the same for children. We should be making sure that children have an inhaled corticosteroid as well. Every adult and adolescent with asthma should have an ICS containing controller medication, even people with infrequent symptoms. And then they go on to say that every patient should have a reliever, and that could be SABA or it could be ICS formoterol. But then they add that ICS formoterol is actually the preferred reliever treatment because it reduces the risk of severe exacerbations, which we've just seen in the data. We have to be careful that we can't use ICS formoterol as a reliever if we're using a different ICS LABA as the person's maintenance treatment. So, for example, if somebody's taking Relvar once daily, they can't use ICS formoterol as the reliever. So you have to bear that in mind. So on to treatment algorithm 1. And there's just 3 things that I'm going to point out. Go and have a look at it in your own time. But there's 3 key things that I want to point out about this treatment algorithm. The first thing is that there are 2 entry points into this treatment algorithm. So for your patients with who you might consider mild asthma, with infrequent symptoms, you might want to start them straight at an as-needed anti-inflammatory reliever therapy. You'll start hearing it called AIR. And that is with Symbicort 206 Turbohaler as per our formulary here in Sheffield. There's a second entry point into that algorithm, and that's for you people who are getting more frequent symptoms. So they might have symptoms almost daily, or they might be waking up with their asthma. So actually, possibly they don't fit into that category where as-needed treatment would be appropriate for them. So we want to put those people straight onto a maintenance and reliever therapy, where they're actually taking a fixed dose morning and night, and they use the same inhaler as their reliever. But you've already told us that they're rubbish at complying with that. It doesn't matter, because they're still going to take the ICS formoterol as a reliever when they need to. The second thing that I want to point out is the red writing, which will be really difficult, I'm sure, to pick out on this slide, and I apologise for that. But that is our safety netting. I want people to have the confidence to be able to go and use these treatment strategies out in with our patients in primary care. And so we want to be able to give you some safety netting advice to give to patients. What is it that I'm looking for that might be too much, in terms of this patient? So we know that step one, the as-needed anti-inflammatory reliever therapy, is just for our patients with infrequent symptoms. If they're starting to need to use it more regularly, then that's a sign that we need to think about stepping up their treatment. But we do want to give people the flexibility to be able to up and down their dose as they need to, because that's the whole point in it. When they're worse, they take a bit more, and when they're better, they might not take any at all. And we want to give people that flexibility, but we want to kind of try and catch them before they escalate too far. So I talked with the consultants, and we decided that what would we be comfortable with people doing themselves, and that is up to 4 puffs, okay, in a day, because that then takes them into medium dose ICS range. So what we say is, if they've got themselves to the point where they're taking 4 or more puffs a day persistently, then that's a sign that they don't fit into that as needed, infrequent, mild asthma group, and we need to think about moving them on. Equally, if they ever need to take 8 puffs in a day, that's a sign that something's really not right, and we need to think about getting them in for a more urgent review at that particular point. And the third thing that I want to point out about this is the box that we're talking about, SABA and flexible regimens. So as a general rule, patients shouldn't need to have a short-acting beta agonist if they're on one of these treatment strategies, okay? There may be circumstances where you feel that that's appropriate for them to have an emergency pack of a salbutamol inhaler and a spacer. Children might be one of them. Your adolescents around about 12, 13, 14, 15, your younger adolescents, you might feel that it's appropriate for them to have that, but that's what it is. It's an emergency pack, and it doesn't come out of the, unless it is an emergency or in that red zone of their personalised asthma action plan at that point. There might be the odd person who you think might not be able to use a dry powder inhaler if they've got an exacerbation of their asthma. It's unusual. The studies do show that people can use dry powder inhalers during an exacerbation, but your patients better than I do, and so therefore we need to think about doing what's right for our individual patients. So just wanted to highlight a couple of the tables that are in there. So we've got this table, which is all of our dry powder inhalers. These are all those lower carbon footprint inhalers, appropriate for adults and children 12 and above. And a separate table of all of the PMDI type inhalers as well that we have available. In terms of children, what we normally say is around about that sort of transition between primary and secondary school, sort of 11, 12 years of age is kind of appropriate to start thinking about a dry powder inhaler. Particularly as I don't know many adolescents who'll carry a spacer around in their blazer pocket at school. So actually you could find that it's far better for them to have a dry powder inhaler without the spacer. I'm only going to very quickly touch on this, and this is the children's algorithm. We don't yet, and hold that thought, have any of these flexible regimes available to us for under 12s, okay? The Symbicort is the only one that we've got on formulary that's licensed from 12 years and above. Not yet. It's possibly coming. So watch out for that. And hopefully the next time we're stood here, we'll have something available to talk to you about that. But this is pretty similar to what you're familiar with in terms of the British Thoracic Society guidance for children under 12, with you're starting at very low dose ICS, the paediatric dose of ICS, adding on montelukast for your under 5s, and then referral into specialist care. For your over 5s, stepping up to a low dose ICS and considering a low dose ICS LABA before then referral onwards if we're wanting to go into sort of higher therapies for our children under 12. The only one sort of slight deviation that we made from BTS in this guideline is that BTS had very low dose ICS and then very low dose ICS LABA. But the one thing that we want to do is really encourage the use of combination inhalers, and you can't actually give the appropriate dose of a very low dose ICS LABA, because actually what you end up giving is the right dose of ICS and a subtherapeutic dose of the LABA if you're doing that for children. So that's why we've done that step up to low dose ICS first, so that we can keep with the combination inhalers. We do have a table for children as well. All of the inhalers fit onto one slide for this one. So we've got the PMDIs and the dry powders. As I've said, PMDI plus spacer is the preferred treatment for children under 12. You can think about it around that transition to secondary school, considering dry powder inhalers where they might be appropriate for the children. But every child's different. You know, you might have a 12-year-old, a really small, petite 12-year-old who struggles to get the inspiratory effort for a dry powder. You might have an 8-year-old who can absolutely get that inspiratory effort. So again, it's all about individualisation. It's another pat on the head. So this is, and I get very excited when I see this chart because it's really good and it shows that we're doing really well in Sheffield. I haven't put on our other counterparts in the rest of the ICB, but I should have done. But if you ever look at open prescribing, go and have a look at Barnsley, for example, and you will see how they're doing. So this is our prescribing of short-acting beta agonists. Now, we have done really well long-term on SABA prescribing because we've long advocated for early initiation of inhaled corticosteroids and not having SABA on its own in the algorithm. But we sit on the 13th percentile now, nationally, right down here in terms of our SABA prescribing. So that's, a real big pat on the head to everybody out there, because we can write these guidelines, but without you guys implementing them out there in practice, we don't see things like that. What we've seen is since 2023, beginning of 2023, when we launched this guideline, quite a considerable drop down as well, different to what we've sort of seen for the rest of the country as well. But, and I'm going to sort of finish almost on this one, I'm not one to look at one piece of data and go, "Ooh, we've done it, we don't need to do anything else now." This is Sheffield, and the red bounded areas are the areas, the top 20% in the index of multiple deprivation. So the top 20% deprived areas in Sheffield. The green dots are either a single practice or multiple practices who we have RAG rated as red for SABA prescribing. So that is that 30% or more of the patients are receiving 6 or more SABAs in a 12-month period. And it kind of hits you in the face, really, doesn't it? You can see where those green dots are. So it highlights a health inequality that's out there, and it highlights what Artie said earlier about the poorest people getting the worst asthma care. And so we know that we've still got work to do. And if you can identify yourselves on this, I apologise. But if anybody wants to talk to me, drop me an email, because we are hoping to do some work with some of those practices in the next 12 months. It's another one of Francis's drawings that I thought I'd leave you with, keeping people away from the cliff edge, not having them fall off that cliff edge. So my last thing is that one of the pieces of work that I want to do in the next 12 months is to set up an ICB Respiratory Champions Network. It's something that I have quite a passion about. what I want to do is try and create an army of people on the ground that are going to influence this change. So there's a QR code on there. Please do scan that QR code and complete the expression of interest form, because when we set up this Respiratory Champions Network, we want to be able to help you and supply you with the tools and education and advice and support that you might need to implement these changes within your practices if you haven't done so already. So it's open to anybody. It doesn't matter what profession you are. We'd like to see a wide variety of professionals within this Asthma Champions Network. So that is me, and I think I'm not sure how far behind. I think I've done quite well actually in my time, and I'm quite impressed, which is quite unusual for me. I'm more than happy to take any questions, and if you've got any questions for Artie, I'm sure Artie can come back up because we've got a little bit of time before the break. Any questions? I think we've got a mic somewhere as well if anyone's got any questions. Silence. Are you all still shocked about the fact that salbutamol can cause inflammation? Has that actually been blown everybody's minds? Right, well, I think we might be kind of early break. There's lots of stands. Please do go and see everybody and get some information from them. Thank you.